Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Alfadel Alshaibani. Okay, here we go. So today what I'm going to talk about is basically unraveling the role of CCR4 chemokine co-receptor 4 in targeting basically in cutaneous T-cell lymphoma. This is my disclosure. We'll start by cutaneous T-cell lymphoma overview. As you know, when it comes to systemic lymphoma, majority are actually B-cell lymphoma, around 80–85%. 15% accounts for the T cells and NK cells. When it comes to cutaneous T-cell or cutaneous lymphomas, exactly the opposite. Majority of cases are actually T-cell lymphoma, what we call it cutaneous T-cell lymphoma, which accounts for around 80% of the cases. For the rare minority of cases, 20–25% cutaneous B-cell lymphoma, and those even B-cell lymphomas, urinary, they are indolent, they are very responsive to localized therapy. Our focus today will be about cutaneous T-cell lymphoma. So this is the latest WHO EOTC classification of cutaneous T-cell lymphoma. Majority of these cases are actually under the category of mycosis fungoid Sézary syndrome, accounts for around 70% of the cases. Then you have other lymphomas that can mimic mycosis fungoid and Sézary syndrome, such as adult T-cell leukemia lymphoma, which we don't see here in the region. It's usually in Japan and in the Caribbean. You have the extracutaneous NK T-cell lymphoma, which can share a similar morphological appearance of mycosis fungoides and Sézary syndrome. So Sézary syndrome is a multi-compartment disease. Majority of the cases, yes, stick to the skin. Okay, it involves the CD4 memory cells of the skin. However, the disease can spread to lymph node, can spread to the blood, and can spread to the viscera as well. On an initial assessment and subsequent assessment by a lymphoma doctor, these sites should be reassessed for the presence of the disease because the treatment really varies, depends on what stage you're dealing with. Majority of cases are actually limited, but around third of the cases, they go beyond the skin. So chemokine co-receptor 4 is a marker that is present in many cells, in T regulatory cells, in CD4 homing T cells, in cutaneous lymphocyte antigen T cells, etc. This chemokine co-receptor 4 is highly expressed in mycosis fungoid and Sézary syndrome, and is present as well in adult T-cell leukemia lymphoma. Actually, the treatment mogamulizumab for cutaneous T-cell lymphoma was started initially on adult T-cell leukemia lymphoma cases. This marker, CCR4, it's a ligand for CCL17 and CCL22. This has a very important pathophysiology in cutaneous T-cell lymphoma cases. This is basically links the blood compartment to the skin compartment, and this is how the malignant cell infiltrate. As you can see here in the picture, CCR4 interact with CCL17, CCL22, and this step considered crucial for migration from the blood component to skin component and to the pathophysiology of the disease. This marker is highly expressed in mycosis fungoides and Sézary syndrome, and this is how you can see it in here. In minority of normal, healthy-looking T cells, it's expressed around 20%. But however, when it comes to the disease, it's a higher frequency. Because this CCR4 is an important target for therapy, it's an important pathophysiological, has an important pathophysiological role in the progression of the disease. This is a target for an excellent medications, and several medications target CCR4, and we'll come to this. For example, mogamulizumab, which I'm going to talk about today, is a target CCR4. Pixarotene retinoid, which is commonly used in a less advanced disease, again suppresses CCR4 expression, as well as vorinostat. Vorinostat actually because vorinostat is a histone deacetylase. Deacetylhistone increases wrapping of DNA around the histone, decreases the expression, subsequently decreases CCR4 expression. So let's dive more into mogamulizumab. Mogamulizumab is an anti-CC4 antibody. It basically binds to CCR4 on the malignant cell and basically recruit natural killer cell to release cytokines to kill the cells, or in another way, it's an antibody-dependent cellular cytotoxicity mechanism of action. The study that put mogamulizumab on the map is basically the Maverick trial. In this trial, patients with from stage 1B to stage 4B, histologically confirmed mycosis fungoides and Sézary syndrome, who at least progressed through one line of therapy, who had an adequate performance status, were randomized to receive either mogamulizumab or vorinostat, and the treatment continued until progression of the disease or untolerated toxicity. Please note that CCR4 expression was not mandated in this trial, so in reality we don't test for this medication, for this marker. If you look here to the baseline characteristic of the study, actually it was well balanced between vorinostat and mogamulizumab in terms of age, in terms of performance status, in form of whether this is a mycosis fungoides or Sézary syndrome, and even when it comes to the clinical stage of the disease. The median number of prior systemic therapy was around 3. And the primary endpoint for this trial was the progression-free survival. As you can see here, mogamulizumab is superior to vorinostat when it comes to median progression-free survival of around 7 months compared to 3 months. And this is a common theme when it comes to cutaneous T-cell lymphoma in general. With other lymphoma, with other systemic lymphoma, diffuse large B-cell lymphoma, Hodgkin lymphoma, etc., your target here is cure. However, for cutaneous T-cell lymphoma, unfortunately, cure is not attainable unless you do an allogenic stem cell transplant. Other modality, sort of prolonged remission, switching between therapies, taking the therapy that has the most higher chance of CR and longest duration of CR as well. And this is where mogamulizumab excel at. If we look here to the subgroup analysis, it really doesn't matter if the patient is age is young or old. I have to mention that the median age here in this trial was around 60, 65. This is opposite to what we see here. Majority, I can tell you from my experience, we do have a multidisciplinary cutaneous T-cell lymphoma clinic in King Faisal where we get referrals from all over the country. And the median age I can see here is 40, around 50, 30 years of age. So the age difference, I would say, is different than the Western population. You see responses whether this is a mycosis fungoides or Sézary syndrome, and of course, the more advanced the stage of the disease is, the higher the response. So looking here into the overall response rate of mogamulizumab was around 30% compared to around 4%. And this is higher as you go. So stage 4 disease actually is around 40%. Median duration of response is actually as well longer with mogamulizumab compared to vorinostat. If we look to the compartment, all the compartments show the response, but the highest seen in blood compartment. And this is something that we'll see in subsequent slides. Patients with Sézary syndrome who have a high Sézary cells in peripheral blood, they do have a higher response to mogamulizumab in comparison to any other agent. This is the best. This is a waterfall plot for the best skin responses. As you can see here, it's highest with mogamulizumab. When it comes to safety, side effects leading to discontinuation of the therapies occur around 20% of the patients. This is mainly a skin reaction, skin ulcerations, or infusion reactions, leading to death around 1% only of patients who took mogamulizumab. When it comes to the safety, the drug is pretty safe. For infusion reaction, it happens around 30% and usually happens with the first couple of doses. A skin eruption can happen as well in 20–30% of cases. This typically happens 3 months, 6 months on treatment, does not happen with the start of the treatment. And this actually correlates with the response, especially with patients with Sézary syndrome. This is similar to the common phenomena with cetuximab, with other targeted agents in solid tumor. In summary, for Maverick trial, this is the first randomized 3 trial that looks into the patients with cutaneous T-cell lymphoma, and the progression-free survival was the primary endpoint. Mogamulizumab was associated with a higher response rate in all compartments, especially in blood compartment, in which you're talking about 70% compared to 20%. Several post-hoc analysis was done on this Maverick trial, which looked into many different aspects of patients' population. For example, the number of prior systemic therapy. For mogamulizumab, it doesn't matter whether this is the first line of treatment or this is the third or fourth line of treatment. This is opposite to the ECP, extracorporeal photopheresis, in which there are evidence that it should be incorporated. If we're going to use it for a Sézary syndrome, it should be incorporated within the first 2 lines of therapy. Beyond that, the efficacy of ECP in treating Sézary syndromes is less evident. When it comes to mogamulizumab, it's seen across, regardless of the number of prior therapies. This is, you can see it here, you see responses whether the patient received a targeted agent, romidepsin, methotrexate, interferon, ECP, pixarotine. You still continue to see responses with mogamulizumab. Time to next treatment, because higher progression-free survival with the mogamulizumab, time to next treatment with mogamulizumab is longer, as expected, and this is you can see it as well. And with the higher the stage of the patient, the longer duration of response. So stage 3 or 4, their median time of response was around 12 months. What about concomitant steroid use? Cutaneous T-cell lymphoma, because it involves many compartments, we usually combine systemic therapy with the skin-directed therapy. Part of the skin-directed therapy is steroids, which can be applied locally, and sometimes even in acutely ill, itchy patients, you can give them oral steroid just to alleviate the itchiness and improve the patient's symptoms. So the question that was raised, whether really concomitant steroid can it really dampen the response of mogamulizumab or not, and the opposite is true. Actually, giving steroid with mogamulizumab increases the response rate of mogamulizumab, as opposite to vorinostat. If you look here, patients who were on steroid, they took vorinostat, steroid does not really affect the outcome of vorinostat, but however it does affect the outcome of mogamulizumab, and this is because you're targeting many different compartments at the same time. You're targeting the skin component. Mogamulizumab is helping with that as well, and you're targeting the blood component as well. So here, the higher the stage, this is a common phenomenon that we see. Higher the stage, the higher the responses to mogamulizumab, and overall response rate with higher with mogamulizumab treated patients receiving concomitant steroid relative to the intention to treatment population. Patients still, as I mentioned, patients who were on steroid and received concomitant mogamulizumab had a higher response rate than a patient who did not. And there is really, when it comes to safety profile, concomitant steroid is pretty safe, did not really alter the side effect expected with the treatment. What about the efficacy and safety on a blood classification, which is basically the main focus of, one of the main focuses of this treatment, because honestly, when it comes to Sézary syndrome, when you have a Sézary syndrome more than 1,000 in peripheral blood, there are really limited options that you can use for these patients. Unfortunately, chemotherapy does not work on those patients. ECP takes around 3-6 months to respond. Mogamulizumab has actually a good outcomes when it comes to blood component, and we're waiting for more and more medications targeting mainly blood component. As you can see here, the higher the B involvement or blood involvement, the higher the response rate to mogamulizumab. As you can see here, B2 more than 1,000 Sézary cells in peripheral blood. The response rate and the duration of response is actually longer, close to 1 year, which is something unheard of when it comes to Sézary syndrome and high peripheral blood involvement. Mogamulizumab looked into the efficacy as well. If you can see here, this is the number of overall response rate. The overall response rate is higher with higher blood involvement, and this basically underlies the importance of doing flow cytometry for majority of patients with peripheral T-cell lymphoma, because you really want to know the percentage of Sézary cells in peripheral blood. This can direct your therapy, whether to go with MOGA or to go with other agents. As you can see here, mogamulizumab, the time to next treatment, it's longer with mogamulizumab compared to vorinostat. And this is the Kaplan-Meier curve, especially in patients with B2. As you can see here, the curve here is the separation of the curve is more evident in patients with a high Sézary syndrome. Patients who do have high Sézary cells involvement in peripheral blood, they do respond better, even when it comes to other components. The higher skin responses on patients with a high blood component. One of the, let's say, acknowledgeable or noticeable side effects of mogamulizumab is a skin rash, and this can be confusing sometimes because cutaneous T-cell lymphoma patients, they do present with a skin rash, they do present with itchiness. And when patients develop a skin drug rash related to mogamulizumab, it sometimes becomes challenging for physicians to know whether they are dealing with a skin rash related to mogamulizumab or actually this is a progression of the disease. So let's look into the drug rash associated with mogamulizumab. This happens in around 20% of patients, leading to discontinuation of around 7% of patients. Majority of patients, even if this happens, you can give them steroid, hold the medication for some time, resume the medication, and they have a good tolerance to the drug. As I mentioned, it happens around 20% of the patient, the drug rash. However, leading to discontinuation of the treatment happens in only 7%. Taking a skin biopsy is very important in these situations to figure out whether you're dealing with a drug reaction versus an actual disease of progression. And this happens as well it's higher with Sézary syndrome compared to mycosis fungoid. Good to know that in the trial they did not notice any Stevens-Johnson syndrome or toxic epidermal necrolysis. Actually, having the presence of drug rash correlates with a higher response, especially in patients with Sézary syndrome. So the proportion of Sézary syndrome responders who developed a drug rash was significantly higher than responders without rash. So developing the skin rash on patients who have Sézary syndrome may give you a hint that this patient is actually responding to the treatment. But however, you need to address the drug rash first and then continue on the treatment. This is not true when it comes to mycosis fungoid, so there is really no difference in a responder who developed rash versus a responder who did not. Overall, the median time, as I mentioned, for developing a drug rash is around 106 days, around 3 months. The initial drug rash occurred after responses to mogamulizumab. However, majority of those patients can continue on the treatment and can resume the treatment. This leads to discontinuation of the medications around 7% of patients only. How to manage these skin rashes? If this is a grade 1, you're allowed to continue the treatment and use topical steroid. But however, if it's grade 2 or higher, this treatment should be stopped for sometimes give topical steroid. I sometimes use even systemic steroid, though in the trial was prohibited for sometimes until the skin rash is under control, and then resume again mogamulizumab. And for my own experience, I've seen good responses with this methodology. Quality of life is a very, 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 very important measures when it comes to patients with cutaneous T-cell lymphoma. Remember, this is a very disfiguring disease. Patients, they do have a huge psychological burden when it comes to the disease. This is a disease the patient continues scratching all day long. their face may be disfigured. People are looking to them at the street. They cannot go outside. They cannot socialize. So this quality of life is a very important metrics when it comes to the treatment of any patients with cutaneous T-cell lymphoma, and when it comes to the assessment, the skin dex 29 symptoms, which basically looks into many of the skin component and quality of life components. This was higher in patients treated with mogamulizumab. Of course, this takes some time, so you don't expect it to happen within 2 weeks or 1 month. The patients start to notice an improvement after a couple of months of treatment. As you can see here, when it comes to emotion, it's higher on patients who took or received mogamulizumab. So in summary, CCR4 is an important receptor for skin trafficking T cells, and this marker is highly expressed in all mycosis fungoides and Sézary syndrome. Mogamulizumab is the first in-class human anti-CCR4 monoclonal antibody that demonstrated efficacy over a standard of care vorinostat in previously treated patients, especially in blood component, in which you see a response around 70% of patients. Mogamulizumab is associated with a higher quality of life, as well as higher response rate. Rash is common with mogamulizumab. However, it leads to discontinuation of the treatment in minority of cases, and mogamulizumab can induce a long-term remission in preclinical models. This is my presentation, and thank you.